So I'm going to try and talk about hypertension and preeclampsia in terms of sort of more focusing on medical management of hypertension and a little bit about pathophysiology of preeclampsia, PLGF-based testing, which I know Nat's already touched on. Every time we do APAM study days, we give a slightly different combination of talks in a slightly different order with slightly different combinations of slides, and I've never got any idea how long the talk's going to take. So I'm going to try and do this in about 45 minutes. I think that's ambitious. So I'll do my best, and I want to just try and leave a bit of time for some discussion and ask questions. So please do, perhaps in the interest of time, I'll just whack through it. Make a note of anything you want to ask, and then let's do a big round of questions at the end. Does that sound all right with everyone? And please do ask. This is supposed to be, an opportunity to discuss. Okay. So I'm going to talk about treatment of hypertension, a little bit about pathophysiology of preeclampsia, and a little bit about the management of preeclampsia. How many people work in intrapartum settings? Quite a few. Okay, so I wasn't going to spend too much time on preeclampsia management, but I will touch on it because there are a few people here. Okay, so I think that's probably already shown you this slide in terms of the general principles of antenatal care for women with hypertensive disorders. We're basically trying to identify hypertension, recognise it, manage it, and prevent complications. And that, in simple terms, is what we're trying to do. And when it feels completely befuddling, when you've got a woman in front of you who's got hypertension and you're really worried about her, just try and go back to those basics. What is it that you're worried about? And that often is related to what gestation the woman is. Is this new or is this existing hypertension? And what are the complications? What are the things that you're worried that this woman in front of you might be at risk of? And that often just helps to settle the mind. And as Nat says, when you've got a woman with a blood pressure of 160 over 110 at 12 weeks of pregnancy, that's a very different set of anxiety than it is if she's 39 weeks. Yeah, so she doesn't need to go to A&E. She doesn't need to be, she's been walking around that blood pressure for weeks. It's not a pregnancy pathology. So it's really important to just try and risk stratifying your head rather than just looking at the number. Sometimes we get a bit fixated just by the number, don't we? Okay, so this is just a little reminder about the importance of hypertension. Who here in their hospital has got a specialist hypertension service? Okay, let's have those hands a bit higher. This is mine. Okay, so a handful, which is great. Might be from the same hospital, but a handful, that's great. How many here has got a specialist diabetes service? Okay, why the heck is that? Why is that? Okay, let's just compare these two conditions, okay? So they're as common, they often predate pregnancy. The pathology and the likelihood of pregnancy complications is higher in your population with hypertension than it is in your population with diabetes. There's a horrible risk that these women are going to get worse after their pregnancies. You're going to hear about it this afternoon, lifelong consequences, just like diabetes, having hypertensive disorders of pregnancy. And yet every hospital around the country has got a diabetes clinic, but very few, as we've just seen, have got a hypertension clinic. If you take nothing home from today, go back to your hospitals and start the fight. Why have we not got a specialist hypertension service looking after these women, cohorting these women, and improving practice and care for these women? It's really silly, and we need to recognise it and do something about it, and that's on all of us. Okay, so a couple of details from the NICE guidance. Many of these will have already been covered, but just for in terms of the women that do come through the service for preconception counselling or at the beginning of pregnancy, very important that we're having conversations with women about medication, what medications they're on, what medications we should be stopping and starting. I suspect you all know that ACE inhibitors and ARBs are contraindicated in pregnancy. I speak to a lot of women who are on these medications outside of pregnancy. If women have accessed preconception care, It means they're taking notice, they're planning a pregnancy. I have no qualms at all about those women staying on those medications until they have a positive pregnancy test, as long as they're monitoring and they know what to do at the point that they have a positive pregnancy test. You've got ample time to get those medications stopped. For a woman who's got bad hypertension, particularly if she's got renal hypertension, particularly if she's got diabetes and hypertension, her ACE inhibitor is going to keep her much healthier in the long term. And if you stop it and she goes on to a crappy antihypertensive for the 2 years it takes her to get pregnant, that's actually going to do her a lot less benefit. So if women have accessed preconception care, they have self-identified as a group of women who are responsible and able to manage their medications as long as you give them a plan. So that's really worth and important. Same thing for women with diabetes. Obviously, once they are pregnant, we do need to stop ACE inhibitors and ARBs and other thiazide diuretics because they are contraindicated in pregnancy. I've got a horrible feeling my slides are moving on. One of those mystery things. So talk about safe medications in pregnancy. Women, understandably, in pregnancy are very nervous about taking any medication, aren't they? Women don't like taking medication. And we often just throw pills at women and expect that they have the same level of kind of safety awareness, or that they are as confident as we are that that medication is okay to take. I'm sure you've all had lots of conversations with women in pregnancy where you've given them aspirin, or you've advised that they take nifedipine or labetalol, and they've actually very worried about taking that medication. They're not, my slides are doing something weird. They're worried about taking those medications. We know that aspirin's safe. We know that labetalol, nifedipine, lots of other antihypertensive medications are safe. But if you don't say that to the women, really reassure them, you can give them all the pills you want, they won't take them. So it's really important that we take some time to talk to women about the medications, why they're taking them, and reassure them about the safety of those medications. Particularly important for aspirin. Many women will tell you they're taking aspirin for their pressure. Is aspirin an antihypertensive? Really very crap one. So they're not taking aspirin for their blood pressure, are they? They're taking aspirin to prevent the risk of them developing pre-eclampsia. And often women find it very uncomfortable. They've got to take aspirin and an antihypertensive. So you just need to have that conversation with them. Okay, so this is going to be very worrying if my slides keep moving on. So in terms of women who present in early pregnancy with hypertension, I'm not going to dwell too much on this, but it's really important that we look for underlying disease. Anyone got any idea how many women with chronic hypertension in a reproductive population that hypertension will be secondary to another medical condition? Anyone want to hazard a guess? It's a, say again? Not quite as high as that. It's about 1 in 5. But that's 1 in 5 women who, if you investigate them, will have an underlying cause. Many women will have been investigated previously by their GPs or in secondary care. Ask that question, and if they haven't been investigated previously, you need to think about doing some investigations. Some of those investigations we do on absolutely everybody. Some of those investigations we tailor to the woman in front of us. So take a history and use your clinical judgment. There is no one size fits all, but don't just take all women with an elevated blood pressure at the beginning of pregnancy as equal. Some of those women will need investigations. The most common pathology you're going to find is renal. And so looking for renal pathology is really important. Renal function, assessing for proteinuria, and doing a renal scan. Anyone know what that is? Adult polycystic kidney disease. We find about 2 of these a year in women who have previously not been identified, and that's really important for their long-term follow-up. Anyone know what that is? Very rare cause of very bad hypertension. It's a pheochromocytoma on an MRI scan. So that we found 1. So that is a much rarer condition. We don't do an MRI of the adrenals in every woman. But again, this was a young woman who was needing 2 antihypertensives. She had a normal BMI. She was only about 22. 22-year-old women do not normally need 2 antihypertensives to control their medication. And that's just history taking. Okay, there's a likelihood of there being something atypical for that woman, which is very different from a woman who's 45 with a BMI of 45, who's got a raised BP. the likelihood of her having secondary hypertension is still a possibility, but it's lower, isn't it? So take a history and use your judgment. Okay, proteinuria. Who gets really fed up with proteinuria and confused about what to do? So proteinuria is a bit frustrating. It's a bit like the raised ALT. It's the bane of our life because sometimes it's really important, and often it's just it's a gestational phenomenon that just needs to be watched. So there are only 4 causes of proteinuria, and again, when you've got a raised PCR, just think about what those 4 causes might be. And the gestation of the woman in front of you is going to be your first clue as to what the cause might be. So if she's got proteinuria at 16 weeks, has she got preeclampsia? No. Does she need to be admitted and go to an AAU immediately? No. She's got a chronic proteinuria problem which needs investigation. She's probably got some underlying renal disease, most certainly, that may or may not have been previously diagnosed. If she's got proteinuria at 28 weeks, all of these are on the cards, aren't they? So the things that will help you there are, has she previously had proteinuria? So is this new or is this existing? Have we excluded a urinary tract infection and then repeated the proteinuria if she did have a UTI? Have we thought about the risk of preeclampsia? We're going to come on to that in a minute. If we've excluded preeclampsia, we thought about renal disease, in which case we need to do some renal disease investigations and refer her to an appropriate antenatal clinic for ongoing management. And for many women, they have this diagnosis of exclusion, which is gestational proteinuria. You can only make that diagnosis of gestational proteinuria when the pregnancy is finished and the proteinuria has gone away, okay? So lots of women with proteinuria do need continual surveillance, not like 3 times a week, once every 3 or 4 weeks. They need to be monitoring their blood pressure because they're at risk of developing preeclampsia like anyone else is. And if the proteinuria has gone away at the end of the pregnancy, then, and you've not found any structural or other immunological evidence of renal disease, then you can label it as gestational proteinuria. So you've got to be in for the long game with proteinuria, but don't over-egg the pudding in terms of there's lots of women bouncing into day units all around PCRs of 42 that do not need to be bouncing into day units 3 times a week. So assess the risk. And try and remember to think about the diagnosis, document the diagnosis, and make a plan that's appropriate for that diagnosis. Okay, a little bit about management of hypertension in pregnancy then. That's already talked a little bit about why we treat hypertension in pregnancy. And I don't necessarily put these bullet points up because you don't know this information, but your women don't know this information. So women will be like, well, you know, my GP's never been worried about my blood pressure of 150, 100 or 145, 95. Why are you suddenly worried? Why do you want me to take these tablets in pregnancy? They make me feel a bit crap. I don't like them. I don't want to take medication in pregnancy. What is the justification for taking antihypertensives in pregnancy? So you need to have these numbers at your fingertips. And this information is available on the APEC website in terms of the leaflets that have been created. It's in the NICE guidelines. So do just have these numbers at your fingertips and reassure women that normalising their blood pressure is beneficial to them. And there have been now at least 2 large RCTs which have demonstrated the benefit of chronic treatment of hypertension in pregnancy. And this is the recent third RCTs, which is called the CHAPS trial. And the CHAPS trial demonstrated pretty conclusively, in my view, that the number of women who had a composite outcome in that middle section there, preeclampsia with severe features or a placental abruption, was reduced in women who had blood pressure monitoring and normalisation of their blood pressure antenatally. So it's really important that we give women the confidence and that they understand and buy into why we're managing their blood pressure and why it's important to take antihypertensive medication. The other thing is that the guidelines are really straightforward. So the blood pressure targets are the same for all types of hypertension in pregnancy. So you don't need to panic, you don't need to remember different numbers. Just like diabetes, the targets in pregnancy are exactly the same for all types of diabetes, they're the same for all types of hypertension. So treat if the blood pressure is persistently above 140 or persistently over 90. Don't do 4 blood pressures that are all above 90 and then one that's below 90 and say, oh, she's fixed, I'll discharge her from triage. How often does that happen? Next time she comes, guess what her blood pressure is going to be? Above 90. So don't take 4 blood pressures and just choose the one that you like. Look at the pattern of those blood pressures, look at the profile. Often ignore the first one. The first one is often ropey. But if you've got 3 or 4 blood pressures where the blood pressure is either above 140 or above 90, be confident she's got hypertension. Okay, she's not got a bit of bubbly, I'm a bit stressed out. She's got hypertension. So she needs monitoring and she needs talking to about treatment. And you can give her a low dose treatment, which is only going to shift her blood pressure by a few millimeters of mercury. You're not going to make her fall over with 200 Pt1 3 times a day or 10 milligrams twice a day of nifedipine. That is a safe intervention, and that's much safer than letting her just waft off with a much higher blood pressure over the next few days or weeks. So be confident about making the diagnosis and write things in your notes like 3 or 4 blood pressures above treatment threshold. Ask doctor to prescribe antihypertensive medication, or if you are the doctor, prescribed antihypertensive medication. So don't shy away from it. We've really got into a bit of a culture of tablets. I get that. Women don't want to take them, so I get that. But the thing is, if you've diagnosed hypertension in pregnancy, most of the time, the only thing that's going to happen is it's going to get worse. It's very unlikely it's going to get better. As long as you've properly documented it and it is persistent, then it needs treating. Once they're on treatment, you're aiming for 135/85-ish. Over-treating blood pressure is now being pretty conclusively demonstrated not to increase SGA rates. Both the CHAPS trial and the CHIPS trial both demonstrated that treating hypertension doesn't cause babies to be being small. Women who've got hypertension have smaller babies, but us treating their hypertension does not cause their babies to be small. And that's another thing that is really important to confidently communicate to your women so that they feel able and confident and happy taking antihypertensive medication. Everybody happy with that? Oh, on that list. Okay, which antihypertensive agent should we use? Well, we really don't have very good evidence at all. And many of you will have recently taken part in the Giant Panda study. And the Giant Panda study recruited women across the UK looking at recruiting women to treatment with nifedipine or labetalol. I'll come back to that in a second. These are the 3 most commonly prescribed antihypertensive medications. All of them have pros and cons. All of them have side effects. What's really important is that they're safe, and what's really important that we understand who they should be prescribed, what doses they should be prescribed and what frequency, and that we accept that they don't all work for all women. So if your first antihypertensive of choice doesn't work either because the woman can't tolerate it or because it's not shifting her blood pressure, then offer her an alternative treatment. Don't just persist. I mean, obviously you might increase the dose, but switch over to a different medication if it's not working. The Giant Panda trial is no longer ongoing. Actually, it's finished recruitment. I should have reduced that, but we've basically recruited 2,230 women to this trial up and down the country. 50 plus maternity units took part in this trial. Women with chronic hypertension, gestational hypertension and pre-eclampsia have been included in this trial, and we will have the first really decent RCT evidence comparing labetalol with nifedipine, and we'll be able to answer a lot of questions about that many of you will have about does beta blockers really work in Black women, for example? Does nifedipine work better in this group or that group? We've previously got no evidence on that at all. So anyone who thinks they know the answer to that question does not know the answer to that question, but we will have a much better idea when we have done this trial. We'll also be able to look at things like neonatal hypoglycemia, for example, which we all associate with labetalol, probably just as common in babies with exposed to nifedipine, probably attributable to prematurity and smallness rather than maternal exposure to labetalol. So those are other things that we will be able to interrogate as part of the Giant Panda trial. So the results will be out probably at the end of this year.